So my name is David Wraith, and I'd like to thank you for joining this very special webinar celebrating the discovery of insulin by Frederick Banting, Charles Best, and John MacLeod at the University of Toronto over a century ago. In fact, the headline of the Toronto Daily Star around that time in 1922 read, "Toronto doctors on track of diabetes cure." So it's now a century later, and we're here to discuss how work on type 1 diabetes has progressed into the 21st century and how the University of Birmingham is playing an important role in this. I want to welcome all of you as friends of the university to hear the views of our experts in the field and for you to challenge them with questions of your own. First, I'd like to remind you that this webinar will be recorded, but only the speakers will be captured on the recording. I know many of you will have questions, and I'd ask you to submit those questions through the question and answers box or the chat box on Zoom, and we'll do our best to answer them in turn. You may be asked to present your question directly to the panel, in which case your microphone function will be turned on. However, if you'd rather not ask your question or prefer to remain anonymous, just let us know in the question and answer box. It's likely, of course, that we'll receive various questions on the same topic, and these will be merged into a single question. Please be assured that your cameras and microphones will be disabled unless you agree to pose a question yourself. Also, please feel free to make comments in the chat throughout the session. So the chat box will be open and we encourage you to submit through the chat box. And of course, we're welcoming people from all over the world now, from the United States, from Europe, and from the Far and Middle East. This is a webinar brought to you by Bringing Birmingham to You, an event series from the Alumni Office at the university. This gives you, our alumni community, a chance to meet and hear from some of the people leading research in various topics, but today we focus on research into type 1 diabetes. Now, it's clear that despite that proclamation of the Toronto Daily Star, we currently don't have a cure for type 1 diabetes, even though 100 years has passed since the discovery of insulin. Having said that, I personally believe that by bringing together the expertise that we share in Birmingham, we now have that goal within our reach. So I'd like to start by introducing you to our panel for this evening. And I'll ask them to give a very brief overview of their current research into type 1 diabetes. So let's start with Parth Narendran.
Thanks, David. So thank you. It's great to be here this evening. So I am based at the University of Birmingham, same institute as yourself, Institute of Immunology and Immunotherapy. I have an interest in type 1 diabetes. And on the clinical side, so I'm a clinician, half my time is based at the Queen Elizabeth Hospital in Birmingham. And during that time, I look after patients with type 1 diabetes. On the research side, I'm interested in preserving beta cells. How can we identify people who are at risk of developing type 1 diabetes? And how can we go about delaying the development of type 1 diabetes, maybe even progressing to preventing type 1 diabetes in the long term?
Thanks, Parth. So I'll introduce myself. I'm the Professor of Immunology and Director of the Institute of Immunology and Immunotherapy here in Birmingham. Now, I've been working in the field of immunology for over 40 years, first investigating how the immune system protects us against infectious diseases, particularly in my case, influenza. But I also got intrigued about asking why this same immune system in some people would start to attack tissues in our own bodies, leading to autoimmune diseases such as type 1 diabetes, rheumatoid arthritis, or multiple sclerosis. Our own fundamental work in this field has led to the discovery that the immune cells causing these diseases can be switched off by a novel form of immunotherapy that we came across. So we've been developing this approach, and with PATH, we are now ready to test whether this will prove an effective way of stopping the development of type 1 diabetes. So now I'd like to hand over to Tim Barrett.
Thank you, David, and it's a great thank you very much for the invitation to be part of this. So I'm Timothy Barrett. I'm Professor of Paediatrics here at the University of Birmingham and a practicing children's diabetes doctor. I work with my colleague, Dr. Renika Diaz and Parth Narendran, and pleased to say I was in a diabetes clinic this afternoon. My research in the last 30 years has been a lot around rare types of diabetes and type 2 diabetes in children. But in the context of this, it's trying to address the problem of really quite major health inequalities in outcomes of children with type 1 diabetes, so that those from diverse backgrounds seem to do much worse than those from more affluent backgrounds. And we don't understand the reasons for that. So I'm looking forward perhaps to describing that a bit further on in the webinar.
Thanks, Tim. And now Dr. Renika Diaz.
Thanks, David. So my name's Renika Diaz. I'm a paediatric diabetologist and I work at the Children's Hospital in Birmingham. As Tim said, I work closely with him and with Parth, looking after children with different types of diabetes. So not just type 1, but type 2 and sort of more rare forms of diabetes. My main interest is improving health outcomes for all young people who have diabetes, not just through treatments when they are diagnosed, such as immunotherapies that are coming through, but also through screening, working with Parth and his team to detect pre-diabetes to offer a more personalised approach to delaying the onset of symptomatic diabetes.
Thanks, Renika. And Alex?
Thanks, David. Hi, everyone. My name's Alex Woodley. I'm an assistant professor at the university and director of the Cellular Health and Metabolism Facility. Also a former student myself, so here in two capacities tonight. My research broadly looks at how exercise impacts the immune system. So I've done a lot of work just in the general population, looking at how exercise can be beneficial for different aspects of the immune system. But given that we know that the immune system is altered in many chronic diseases, it's led me to work with different clinical populations. And these include rheumatoid arthritis patients, people with lupus, and also most recently, people with type 1 diabetes. So again, I look forward to talking to you about our work a little bit later on.
Thanks, Alex. So now we've come to this session where we discuss a series of topics of critical importance to the diabetes field and to which our panel members have made contributions through their research. And the first question, really, a general question, is what is type 1 diabetes? And why is it important to be able to diagnose the disease as early as possible? So I'll start by talking about the sort of science behind, or the fundamental aspects of type 1 diabetes. And I think it's important for everybody to remember that our immune system evolved to protect us, or rather to protect the species, the whole population, against infectious diseases. That's why those are the drivers that have forged evolution of the immune system. As a result of this, the immune system in humans is incredibly complex and has developed means or ways of responding to virtually any new pathogen that a human being can encounter. Now, no system is perfect, we know that, and occasionally cells of the immune system respond to parts of our body that they should have learned to ignore. And if these self-antigens, as we call them, are recognized in the central nervous system, then an individual may develop multiple sclerosis. If in the joints, it could be rheumatoid arthritis. or in our case, in the pancreas, diabetes. So in type 1 diabetes, these autoimmune cells, or autoreactive cells, cause destruction of the insulin-producing cells of the pancreas to such an extent that the affected child or adult will become dependent on lifelong injections of insulin. So I'll now ask Renika to add a clinical perspective on this and give a brief overview of therapies that are currently available for type 1 diabetes.
Thanks, David. So currently, the only effective treatment we have for type 1 diabetes is insulin that we give via injection through different devices. And as David has mentioned, our bodies are really sophisticated. So if you don't have diabetes, you have these internal systems that work without you having to really do anything to keep your blood sugars really in tight control. And when you've got diabetes, those internal mechanisms don't really function as well as they should because you're not producing the insulin from your pancreas. So there are two aspects to diabetes management. Firstly, knowing what your blood glucose level is, and then so then you can work out how much insulin you need to manage it to get it back into normal ranges. So in terms of blood glucose measurement, if you're a diabetic, you can do a finger prick test before a meal or exercise, or if you feel unwell. But this relies on you remembering to take your equipment out with you, remembering to do the test. And it's obvious that you're doing it, which lots of people struggle with that aspect. So we now have an automated way of looking at your blood sugar. So these are called glucose monitoring devices. And it's a small device about 2 centimeters in diameter that you can wear on your skin. And the two most commonly used ones in the UK are Libra and Dexcom. And you might have seen photos of the model Lila Moss wear her Libra at the Met Gala last year. And these use Bluetooth to connect to a smart device and take blood glucose measurements several times an hour. And they alarm and tell you if your blood sugars are going high or low. The next aspect to your diabetes management is giving yourself insulin. And one option is multiple daily injections through a pen device that you take 2 different types of insulin, one long acting that works through the day and one fast acting that you can take to manage your blood sugars or for a mealtime. The next step above that is a pump device. This again, like the glucose monitoring device, sits on your skin with a small plastic tube or cannula, sitting in your subcutaneous fat and delivering different amounts of insulin depending on the time of day, what blood glucoses you've inputted or what carbohydrates you've inputted. And the latest iteration of this is this hybrid closed loop system, or sometimes called automated insulin devices. And these connect your glucose monitoring device to your pump and adjust automatically the insulin via the pump according to the blood glucose levels detected by the monitoring device. So it will reduce or stop your insulin if your blood glucose is going too low and increase it if it's rising. And the technology has really transformed many people's lives, and for the young people that I look after and their parents, more importantly perhaps, and moving on to this type of technology has meant that, as parents have told me, I can sleep now because they know the pump will suspend the insulin delivery if the blood glucose is dropping. So I'm going to ask Parth Narendran to move on to his work and why it's so important.
Thank you, Renika. And there's a question in the chat. Are these solutions available on the NHS? Do you want to take that?
So in terms of type 1 diabetes, the Dexcom is available to all patients with type 1 diabetes, and pump therapy is available on the NHS, as is hybrid closed loop, depending on a few other different factors like your ability to manage a pump and the glucose monitoring device. But generally, yes. So we've got a significant number of patients both on pump and glucose monitoring devices all through the NHS.
And there's a string of other questions coming in related to that. Maybe we can bunch those up and tackle them later. So the work we're doing, the ELSA study, and Tim and Renika involved with this, is trying to identify children at risk many years before they develop type 1 diabetes. We're working also with Alex Richter, who leads our clinical immunology service at the University of Birmingham. So we're running the first UK general population program screening children for risk of future type 1 diabetes. It's open to all children aged between 3 and 13. We launched at the end of last year. You may have seen it across all the media platforms. It depends on a drop of blood on blotting paper, which is then posted back to Birmingham. So anywhere across the 4 nations. We're still to launch in Northern Ireland and Scotland, but that should happen later this year. So currently Wales and England, if you're interested, log on, register, and we'll post out a blotting paper card and a device to obtain a sample of blood, and that's posted back to Birmingham, and we can test those for antibodies. So this is the immune system that David was mentioning earlier, which for some reason targets and destroys the insulin-producing beta cells. So we can pick these up many, many years before people actually develop type 1 diabetes. And that has a number of advantages. Firstly, we can prepare families for a future with type 1 diabetes. It prevents people being diagnosed as an emergency. Currently, about a quarter of our children are diagnosed as an emergency, and that can sometimes be fatal. I thank you. Someone in the chat has said that they've participated in the ELSA study already. Well, the other thing is that therapies are coming on board which can delay type 1 diabetes significantly. So in the States, we have recently had the license of a drug called teplizumab, which can delay type 1 diabetes for at least 3 years. And we're hoping that that will also be available in the UK and across Europe in the next few years. And that's just the first of many therapies that may come along to delay type 1 diabetes. And we hope, if you look at many autoimmune diseases like rheumatoid arthritis and multiple sclerosis, there are lots of therapies we can offer to families who are at risk, or even with new onset disease, to try and manage the condition and delay the onset and modify the natural history of the disease. And type 1 diabetes currently, as Veronica said, we only have insulin, and hopefully we can move it to a stage where we can offer therapies to change the manifestation of the condition and delay its onset. So that's the work that we're doing in Birmingham. There's lots of people involved in it, not just Veronica and Tim on the screen, but many others behind the scenes who are doing it.
So Parth, a few people have asked the question, what's the difference between type 1 and type 2, and how does that affect therapy? Maybe you and Veronica could comment.
Yeah, so I'll kick off. So it's really important to get that right, because the treatment is different. So if it's type 1, we would go down the insulin line, and there's all the technology that Veronica mentioned. If it's type 2, then you treat it with different therapies. And of course, insulin is also one of them, but there's lots of other things you can try before insulin. It can be really difficult to tell the difference. So Theresa May was misdiagnosed. She was diagnosed in her 40s, but they initially thought she had type 2 diabetes before they realized she had type 1. So it can be really difficult to tell the difference. A test that's come along recently, which may be useful, is the C-peptide test. So this is a measure of how much insulin the body is still making. Just doing that test, it's not so effective soon after diagnosis, but about 3 years after diagnosis with diabetes, that test can help differentiate between type 1 and type 2. That's one test. And the other test, of course, is to measure the autoantibodies, similar to the ones we're measuring in the ELSA study, but measure it in people who are newly diagnosed, and that can also help tell the difference.
Yeah, so just to add to that, so type 1 diabetes is an autoimmune condition. So that's where you basically have loss of your beta cells in your pancreas that produce the insulin. Type 2 diabetes is generally thought of as an insulin resistance syndrome, a resistance condition, where your pancreas is still producing insulin for a significant period of time. So that's where the C-peptide test comes into it. But your cells aren't as responsive to a given amount of insulin. So that's where the difference is. And I think the therapies that David and Parth have talked about are primarily targeting type 1.
That's right. So Tim has something to add as well.
Just ready to say that I've been looking after children with diabetes since the mid-80s, something like that. And I've seen children come in newly diagnosed with diabetic ketoacidosis every 10 days on average through the emergency department. There's been absolutely nothing I've been able to do to stop that at all. This is the first time now with PATH study here that there's the opportunity to identify children before they crash in diabetic ketoacidosis and hopefully give them treatments that will delay the presentation. So I absolutely applaud what PATH and Reinicke are delivering here. This is such an important study for children, and hopefully the new generations won't have to see and rescue children in A&E and not be able to do anything about it.
So Tim, how accessible do you think such a test would be globally? And, you know, it's fair enough detecting disease early, but are there therapies that could be delivered globally?
Well, I'll probably pass back to PATH for this one, but the development of the technology that PATH and Alice Richter are doing with the dry droplet spots should make the ability to do this test much more widely available, and that should really help. PATH, I don't know whether you want to follow that up.
It's a very simple test to do, Tim, as you say, but engaging different communities is challenging. You know, some communities step forward into research studies much more readily than others. So that's a really important part of the ELSA study. Often we find that the communities that don't engage, that engage less with research studies, are more likely to present in diabetic ketoacidosis, as you mentioned. So it's trying to find the best ways to access different communities. And I know that's something you're doing as part of your diversity in diabetes study.
Very good. Okay, so Reinicke, do you
I was just going to say your question around therapies being available. So again, PATH is much better placed to sort of answer this, but there is a therapy that has been approved by the FDA in the US for use in pre-diabetes. So the group of young people that we are screening for to try and kind of reduce their risk of developing diabetic ketoacidosis. So there's a drug called teplizumab that is being used, and I think you're also developing other therapies as well to target this group of patients. But I think PATH and Tim's comments around making sure that this is an equitable offer for everyone who is at risk of, or as many people who are at risk of developing type 1 is really, really important, particularly in a city like Birmingham.
Yeah. So maybe I can just build on this, Reinicke, because and the ELSA study will pick up people hopefully before the immune system has caused so much damage that they become insulin dependent. And I think this provides a window of opportunity, if you like, to stop that progressive march towards insulin dependence in patients. And as you were talking about the teplizumab study, and that this has delayed disease progression, if you like, and prevented people from going into that insulin dependent phase by years so far in the studies. However, it has to be said that this is a monoclonal antibody study or monoclonal antibody treatment that will be expensive because these drugs are expensive to produce. And I think, what PATH and I are now working together on is an approach that, put most simply, is most similar to what people would understand as allergic desensitization. So this is an approach where we administer fragments of the antigens recognized in the disease and effectively switch off the cells causing the disease. So we've tried this in Graves' disease and in multiple sclerosis. And most importantly, the approach, the treatment has proved safe. And there is increasing evidence of efficacy. Now, ultimately, this approach would be much more straightforward and much, infinitely less expensive than the monoclonal antibody approaches. So hopefully, we could identify children or adults at the very early stage of their disease and use this approach to prevent further progression of the disease. So I'd like to turn to Tim to really question about how we approach those difficult populations and try and engage them and improve control in those more difficult populations.
Thank you, David. No, that's grand. So the part that we're addressing at the moment is children and young people who've been diagnosed with type 1 diabetes and are dependent on insulin for their treatment. And we know, of course, that chronically high blood sugar levels can cause eye and kidney damage and, of course, heart disease if not well looked after. And we know that getting better sugar control can reduce that risk of damage. Unfortunately, what we're seeing in the UK is that children with diabetes from diverse communities, by which I mean children of colour from South Asia or African Caribbean, and children from poorer communities or lower socioeconomic ability there, they've got worse glucose control. And some of this is really shocking. So when we look at this, although everybody's sugar control has got better over the last 15 years with technology, the gap between those more affluent populations and those less affluent has widened. And the gap between affluent white children and children from other ethnic minority groups has also widened. And those widening inequalities has got worse during the COVID pandemic. And it's really quite shocking to see some of these as well. We don't know the reasons. We don't know why these populations have a higher risk of complications and more difficult to control the glucoses. So what we're doing is, with the support of our colleagues in Diabetes UK and JDRF, is asking children and young people with diabetes from diverse communities how language issues, feelings, family income, free school meals, other food availability, how that affects how they manage their diabetes. And what we're trying to do is working with them to share their experiences and come up with some solutions in terms of an intervention package that can be delivered across, bridging between the diabetes centres and their communities to try and help them manage their diabetes and get better outcomes, effectively level up, I guess, really, from those who are doing worse to those who are doing best. So working with children, young people, their families and diabetes staff, talking to those who are living the condition. I was fortunate to recruit a couple of families this afternoon. Understand their barriers to better care and find ways to make their diabetes management less difficult. If we can put together a package with these young people, we'll then test it in 2 hospitals. So I've got my colleagues in Leicester and Nottingham kindly agreed to help support that. And then if we do a test run in those and it works, we'll then roll it out into a what's called a cluster randomized trial in 30 diabetes centres across the country. And there's other people on the call who are kindly taking part in supporting that as well. And if we can then show that the package works, we can then persuade the NHS and other providers to hopefully deliver it. And the end of this project, hopefully, will be to reduce those health inequalities to try and make the system more equitable together.
So Alex, Renika and Parth and I have been talking about immunotherapies, but I mean, you're working on, if you like, interventions that don't impact the immune system. Would you like to expand on those?
Yeah, thanks, David. Yeah, so when I joined the university in 2019, I struck up a conversation with Parth, just talking generally about exercise and the immune system in different conditions, particularly type 1 diabetes. And it's led us down a path where we've received funding to look at exercise in type 1 diabetes in a bit more detail. So there is some evidence to suggest that exercise can preserve the health of the pancreas. So it's been mentioned already that beta cells within the pancreas produce insulin, and there is some evidence to suggest that exercise might have this beta cell preserving effect. And this is particularly important possibly for people who've recently been diagnosed to have more functional beta cells. We know even less about the cells that actually do the damage, so cells of the immune system. So this has led us to our current trial, which is funded by the Rose Trees Trust, which is a medical charity in the UK, where we're looking at how an exercise intervention might impact aspects of the autoimmune process in people with type 1 diabetes, specifically new onset type 1 diabetes within 12 months of diagnosis. So we essentially have a method where we can identify cells within the blood that have an affinity for the pancreas, and we're measuring how the number and activity of these cells change over the course of an exercise intervention. The study's running nationally, so we've got sites at the moment in Birmingham, Liverpool, Taunton, London, and we're in the fairly early stages of the process, having a few issues here and there with recruitment. So anyone who's on the call who's been diagnosed within the last 12 months, please get in touch. But you know, in terms of impacts, I think the goal for this study really is to kind of provide more kind of specific evidence that exercise can be beneficial in type 1 diabetes. You know, we all know that exercise is good for us. There's pretty good evidence for people with type 1 diabetes that kind of general health outcomes are improved with exercise, which is great. But really, we're looking kind of on the level of the disease, the level of the immune system and the cells that potentially cause the damage. Can an intervention help with this? And I think that's a really important potential message and impact.
Thanks, Alex. Paz, do you want to add to that?
Yeah, no, I just want to reiterate the sort of part, also touching on Tim's point that engagement with clinical studies across all populations is really important. So, so if people are interested in participating in Alex's study, and Alex, it might be worth you putting your web link on the chat. You've already seen the LSAT web link on the chat. So people interested in taking part in studies, please do get in touch with us. I just want to say that if you look at how type 2 diabetes is managed, we start with lifestyle, so diet and exercise, and then we add, you know, if that doesn't hold it, then you add one medication. If that doesn't hold it, then you progress to a second and a third. And if you think about how type 1 diabetes and many other chronic conditions can be managed, that's probably the way it's going to go. So if we can identify people at risk, not only will we prevent the acute emergency admissions that Tim mentioned, but it would make sense to start with a lifestyle intervention and then move on to other therapies, antigen-specific immunotherapies, as you mentioned, David, but also non-antigen-specific immunotherapies. Hopefully, you know, with time, we can delay it for longer and longer and longer. So that's the thinking behind, I think, behind your work as well, Alex. Is that it'll add to a combinatorial therapy to delay type 1 diabetes long term.
Very good. So just in general, are there any negative impacts of a surveillance study such as this that you can think of, Paz?
Yeah, I mean, so every screening study comes with the potential for harm. So not just the cost implications, but also how will families take it if they're being informed that their child is at risk? How will they take living with risk until the diagnosis comes? So these are all things we're exploring in the ELSA study. Also something we're trying to link up with colleagues internationally about. So we've been talking to Canada to see if they would want to implement something like ELSA in Canada. We've been sharing the protocol with them. And we're linking up with a number of European countries as well to try and develop protocols together. So it truly is an international piece of work, and it's great to have Birmingham playing an important role in that.
And do you think, I mean, could this type of screening approach extend out to other diseases, do you think?
Yeah, so the screening, so the program in Sweden also screens for celiac disease and thyroid disease, and the American program equivalent to ours also screens for celiac disease. So once you've taken the sample of blood, you can check for lots of antibodies. You don't need to restrict it to type 1. But there's lots of implications of that. So how do you follow up people who are at risk? So for that reason, we've just concentrated on type 1 diabetes, but there's always the potential in the future to expand this out to other conditions.
Renika, you had a point.
Yeah, so just coming back to sort of possible less positive implications, I guess. Is around the fact that with screening, you know that you have an increased risk of developing a lifelong condition that will have impacts on your life. But how you manage the kind of the psychology of knowing that you are at risk of developing a condition, but then not having that condition potentially for a number of years, particularly with sort of immunotherapies around the corner. So I think, Parth and his team are very much considering that, and it is an important aspect to think about. And yeah.
Very good. So finally, I mean, before we dig into the specific questions that are coming thick and fast, certainly comments in the chat, there's lots of really useful and important comments coming through in the chat. But if we finish now with our formal questions, and this is a fairly philosophical one, we've looked back over the past 100 years, but what about looking forward 100 years? What will we have achieved? And why do you think Birmingham is ideally placed to achieve this? And I'll put Parth on the spot with that one.
So I think the strengths of Birmingham are the science. We are, we have lots of expertise in lots of scientific fields, and we're, I think, a fairly friendly university. So you can always go and knock on the door and someone in a field completely unrelated and expect to get some support. And so that's how a lot of my projects have started. So I think the science, the healthcare is very strong in Birmingham, but also the population. So we've got the diversity, not just in ethnicity, but also in terms of deprivation. We've got a lot of populations that need a lot of support. So engaging and working with them is very satisfying and also can help address a lot of healthcare issues. And also we're a very stable population. So people who are in the Midlands and in Birmingham they tend to stay. So for long-term research studies and follow-up, that really helps with that.
So Parth, I think we'll move on to the questions that are coming in now. And one that seems to be coming up time and time again is the fact that, and we have a representative from JDRF here, and some people will think of this as a disease of children or a condition of children. And a lot of people are commenting that they've developed type 1 diabetes later in life. Now, you're focusing on primarily the adult population. So, I mean, what would you say about this?
Yeah, so it's important to understand that type 1 diabetes can present at any age. I think the oldest person to have diagnosed it is in their 80s. So it's always important to think about type 1 diabetes. As we get older, particularly into our 40s, if someone's diagnosed with diabetes, you tend to automatically stamp it as type 2. And that's what happened to Theresa May. But it could be type 1. And as we discussed earlier, it's important to get the diagnosis right because the treatment changes accordingly. So, and there's actually some research that suggests that the incidence of type 1 is actually the same all the way up to the 60s, which is the oldest age they examined. It's just that in the adults, because there's type 2 diabetes, it can be mixed and misdiagnosed as type 2 rather than type 1. I think over 95% of diabetes in children is type 1 diabetes. So it's slightly easier to make that type 1 diabetes diagnosis in children, but it's harder in adults.
And similarly, I mean, people have been asking whether there's a genetic component to type 1 diabetes. And I think, the truth is that, as with many other true autoimmune conditions, there is a genetic component to that, meaning that, there is a hereditary possibility of those sets of genes being passed on. But the truth to say is that there are many, many different genes predisposing to this disease. And, it requires a certain combination of those to give that predisposition. Is that correct, Parth?
Yes, I might actually ask Tim to answer that because he's
done
lots of genetics.
No, thank you, Partner. So we know that there's at least 40 different genes involved in the development predisposition to type 1 diabetes, and that people have little combinations of different variants in it that might predispose. But even then, there's a family history of type 1, probably in only about 12 to 15% of families. So there's a lot of families who don't have a family history there as well. So I never want to get too hung up on genes. Genes are clearly important, but obviously there's things in the environment as well, and it's that combination, isn't it, of the environment and the genes
That's right.
diabetes to occur.
And similarly, Tim, I mean, people are asking whether, predisposition to type 2 can impact predisposition to type 1.
Yeah, that is a really interesting question. Certainly, there are some people with type 2 diabetes who have the autoantibodies associated with type 1 diabetes. And at least in childhood, something like 1 in every 10 child with type 2 diabetes has got antibodies for type 1 diabetes. So there is some crossover at the edges there, and that they can predict children, like the child I saw in the clinic today, who's likely to go on and require insulin within the next 5 years or so. But interestingly, the genetics is quite separate. So
Yes.
the genes that predispose to type 2 are quite different to the genes that predispose to type 1.
Yeah. And then other people are asking, okay, so you're looking at using this dried blood spot and antibody screening for diagnosis, early diagnosis. But what can be done at the moment? What intervention can be used at the moment to prevent progression? Renika.
Thanks, David. So I think this is a really important question because it goes back effectively to what Parth is trying to do with ELSA. So teplizumab is one drug. There are going to be lots of other drugs coming through the pipeline that will benefit different people in different ways. So, for example, it might be that with one particular form of immunotherapy, patients who have pre-diabetes with a certain cluster of antibodies positive will benefit, but wouldn't benefit from another treatment. And I think, this field has just exploded, in the last few years through work that you and Parth and others have done. And I think that, we have had insulin for 100 years, but, the next 100 years looks very, very promising because of all the fantastic research being done, not just in Birmingham, obviously, but I'm going to trumpet Birmingham, but in other places as well.
Yeah. So I think it's important to say that, drugs like teplizumab look really promising, but they don't really target the underlying cause of the disease. They dampen it down, and what we're really looking for with the antigen-specific approach that Parth and I are working on is a way of stopping the disease in its tracks. And hopefully, if we can intervene early enough, we'll be able to do that and retain those insulin-producing cells. So, Parth, somebody was asking whether the type of blood spot that you're using for ALSA could be used in very young children?
Yeah, that's a really good question. We're starting at age 3, just to try and address some of the other questions. So we're screening age 3 to 13. And we're starting at 3 because it takes a few years for the antibodies to generate. So if you did it at birth, the antibodies wouldn't be there. So so you could have a false negative. You could reassure people and say the antibodies aren't there, but actually it might come up in the next few years. So that's why we're starting at age 3. We're not going into adults yet, and there is an argument for that. Because the teplizumab drug in the States is licensed into adulthood. So there is an argument for screening into adulthood so that we can offer it to adults. The thing is, we don't understand the natural history in adults as well. So in children, we can say, we can give a fairly accurate diagnosis to say there's a 75% chance of progressing in the next 5 years or whatever, depending on the results of the test. But for adults, we can't say that because we don't understand the natural history yet. So generally, internationally, countries haven't progressed into screening adults. We're thinking of taking the age up, and we're actually actively discussing that currently about whether we should take the age up. And we are open in Wales as well as England to answer one of the questions, and Scotland and Northern Ireland will be starting in due course later this year.
Sure. And I think another valid question, Parth, is, ultimately, if there is a family history of type 1 diabetes, would you recommend screening more often?
So we don't know so just to go over the numbers that Tim also gave. So the prevalence of type 1 is 0.3% in the general population, and it goes up to 3% if there's a first degree relative with type 1. So it's 10 times commoner, but still the chances of not getting it are 97% if there's a first degree relative with it. So should we do serial testing? So does a test at age 3 or 4 mean people will never get type 1 diabetes? And I think the answer to that is probably no, but we don't know yet. So some people are saying we should do a test at age 2 and age 6, and then you'll have a very good idea up into young adulthood that they're not going to get type 1 diabetes. But the Theresa May is people are getting in their 40s, 50s. It may be that the antibodies only come up in the 30s. So that's the sort of natural history we don't understand yet, which we need to if we're going to mount a screening program into adulthood.
Very good. So another question that's come in is whether any psychological therapy would be given alongside any of these treatments.
Yes, so that's a really important part of the ALSA study. So people who are diagnosed at risk are all offered psychological support, not just as part of the education, but we're trying to organize for a psychologist also to call them and see how they're accepting the news and whether they need further support. And the other thing that we'd like to do is set up a peer support program. So people who are identified at risk will have other parents they can speak to, including parents of children who already have type 1 diabetes. So that's come through in some of the early work we've done. I don't know, Ronika, if you want to add to that.
No, I think you've answered that brilliantly.
So Ronika, some questions have come in asking about cures and possibly the use of stem cell therapies for replacing islet cells and things. What do you think of those?
Gosh, that's a difficult question to answer. I might well defer to Tim and Parth.
Yes.
Actually.
So okay, over to Tim. Well, what do you think? I mean, there was a great deal of excitement, Tim, about islet cell transplants some years ago, but is that a really practical option?
Yes, islet cell transplants it was these things that I always get asked in the clinic, when will I have the cure for my diabetes? When will I have it?
Yes.
And,
yes.
and in the early 2000s, islet cell transplants was the great thing, led by the surgeons in Canada who developed it. And the early data did show some effectiveness once they'd sorted out the drugs used to stop the body rejecting the transplanted islets, and making sure the islets still worked at the end of it. However, the practical difficulties remain that there may only be 900 donors a year who've got suitable islets that can be transplanted, so organ donors who unfortunately die. And the number of children and young people with diabetes is over 30,000, and if you take adults as well, we're double that, I would imagine. So that there's never going to be enough islets. And some of the data suggested that people needed 2 or 3 infusions of islet transplants as well. It wasn't just one. Where I think it's increasingly exciting is, as technology gets better, people are learning how to try and engineer pancreatic beta cells from stem cells and the other forms, and that's been a real struggle to get that technology right, as you know, to try and get an engineered cell to behave like a true pancreatic beta cell. But it is getting there, and I really hope, again, you'll know this area better than me, David, that in the next 20-25 years or so, that may become a reality in that time.
Mm-hmm. There would still be the problem, of course, of making those universally available, particularly in less well-off countries. So I think that it's still a challenge, and it would be, in my view, much more sensible and much more straightforward to be able to identify the disease early on. And one point about testing, much earlier in children, and I'll put this to Parth, is whether, in fact, could you not use a combination of genes? For some of the 40 genes that Tim was talking about earlier, to predict children who may develop type 1 diabetes, and then come in with an intervention really early. What do you think, Parth?
Really good question, David. And that's an approach that our Australian colleagues are trying. Mm-hmm. Because it's not a monogenic disease, it's not caused by one gene. Not everyone, you can't pick everyone up just because they've got the risk genes, doesn't mean they're going to necessarily get type 1 diabetes. But what you can do is concentrate the people who are more likely to get it, and then you can do the antibody test after that. The reason we haven't done that is because you're going to miss people. And also people at low risk with the low risk genes can still get type 1 diabetes. So for a number of reasons, we haven't gone into that. But I do think genetics has an important role to play, because once they've been identified at risk, we could then use genetics to help predict how quickly they're going to progress. So currently we measure their glucose and see how wobbly the glucose is to predict how close they are to getting type 1, but genes could also contribute to that. I notice there's lots of questions on exercise. I don't know if Alex wants to.
Yes. Alex, have you been seeing these questions?
Yeah, I've seen a few of them come up. Yeah, so I think a lot's come up about the type of exercise, kind of mode of exercise, and I think Parth, you'll be good to obviously come in on this and talk about your XTOD program, but you obviously need to be really careful when you exercise, because of fear of low blood sugar or hyperglycemia. It's all about managing the amount of insulin you're putting into the body, the type and amount of carbohydrate, and the type of exercise that you do as well. It's all really a competition for the glucose in the body. So if you're putting insulin into the body, it's going to attempt to lower the blood glucose, and the muscle from exercise is also demanding glucose, so it can lead to reduction of blood glucose. In terms of the type of exercise, we know that more kind of continuous aerobic exercise can lower blood glucose levels, whereas more high intensity exercise and things like strength training can actually lead to an increase in blood sugar levels. And this is largely due to the stress response you get from exercise, so higher levels of adrenaline in the circulation. for this reason and around kind of safety, just on our trial, we're running a home-based exercise intervention that we're managing through mobile health technology. So individuals have a wristwatch and the intervention's programmed, and it gives us a chance to communicate with the participants during the intervention and offer them support. And the type of exercise they're doing is something called high intensity interval training. And there's a lot of safety work around this showing that it's really good in terms of stabilizing blood glucose levels during exercise. So, and importantly, not in the immediate aftermath of the exercise, but there have been studies kind of monitoring glucose levels for up to 48 hours after the bout of exercise, showing kind of really stable glucose levels, no kind of increased incidence of nighttime low blood sugars. And this is compared to the more kind of prolonged exercise, like I said, that can have potentially this effect. So it is very challenging, but that's the type of exercise we're using in this intervention. And as I said, the support aspect is really important in terms of this. So we can see with each bout of exercise that the participants are doing, we see their heart rate traces, so we can tell not only if they're doing the exercise, but we can see whether they're hitting the prescribed zones and often feedback. So that's been really important in terms of increasing the enjoyability of the exercise, which is ultimately the most important thing, right? Is for people to enjoy what they're doing.
So other questions, there's lots and lots of questions.
David, I was just gonna come in on what Alex was saying as well. Just that exercise has so many other benefits outside of sort of glycemic control. So I think that aspect, you know, so Alex talked about enjoying the exercise, but there are, you know, other aspects around mental health, long-term, just general health outcomes that also are really important to value in doing exercise. And I think, you know, from my point of view, encouraging young people to do exercise with or without diabetes is really important, and for different reasons.
So yeah, another one for Alex. I guess the question is, exercise is one part, but other people have been asking about diet and particularly fasting diets. In relation to what you've been finding, Alex, would you like to comment?
I actually think Path will be better for this because I'm not actually nutrition based in my research, and I think it's a good opportunity for Path to talk about the XDOD program, perhaps.
Mm-hmm.
Yeah, I can take that, Alex. So there is evidence that exercise preserves B cell function, which is what Alex is also working on. And that's been shown in animal studies as well as in people with type 2 diabetes. And then we've done some work very early on looking at new onset type 1 diabetes, looking to see if it preserves B cell function. And there's a signal that it does. In terms of diet, that's a little bit more challenging because remember, when people are diagnosed with type 1, they've often lost weight, and ensuring nutrition is really important. And in children, nutrition is really important because if you start restricting that, then growth is affected. So there's very few clinical trials of diet in trying to preserve B cell function in type 1 diabetes for those sorts of reasons. It's more the concerns about risk. In some animal models, there is evidence that it preserves B cell function, and we're talking here about calorie restriction rather than low carbohydrate diets, which sort of gives a nod to one of the questions about low carb diets.
So some of the questions coming in, Path, maybe I can pass this on to Tim. And we know that there's a genetic component, but you know, how much do we know about the environmental components that may trigger this disease? And you know, people are asking about stress, people are asking about diet, and what do we know from studies across the world that might tell us something about the environmental factors that impact on this disease?
Well,
Tim, do you want to comment? Yeah.
Yes, I'd be delighted actually. So what we can do is perhaps put in a link in a minute to the excellent review done by Dr. Lauren Quinn, working in Path's group a year or so back, who did a really nice review and a picture of it as well. So people have investigated everything from factors in pregnancy, in the pregnant mums of people who go on to develop diabetes, to what happens at birth, whether it's breastfed or bottle fed. What viruses that children get in childhood, sort of gastroenteritis and other viruses of those forms, all the way through to exposure to animals, having pets in the home, animal factors, to infections, including things like COVID as well. There's slowly mounting a little bit of evidence for some of these, and there are big studies at the moment going on to try and find out whether immunization against certain viruses that cause gastroenteritis might reduce the development of diabetes, and that's being done, I think, in Finland at the moment as well. Others, such as breast milk versus bottled milk, the evidence is less secure, and I think is less thought to be so much now. Yet others, like COVID, the jury is still out really about the part that COVID has played in an undoubted increase in presentations at that time since. But perhaps if we can put in the link, maybe the link to the really nice review paper, people might be interested to have a read of that.
Yeah, I think Path has just put that in.
Yeah.
So going back to COVID, Tim, do you think, was there a reduction in the detection of people with type 1 diabetes during that period where people were isolating? I mean, was there then an upsurge in the number of people coming forward at the end of the pandemic, in your experience?
It's really interesting. I'm really going to have to defer to the person who did all the hard work in that time, because I didn't see so many, but my colleague, Dr. Renica Diaz, did. Renica, you might want to share your experience, because it was pretty...
So I have to admit, in children, what happened was we actually saw the same. There wasn't a massive reduction in new presentations of type 1 diabetics. I think that's the question you're asking, David, isn't it? But what happened was they came in significantly more sick. Because of worries about coming into hospital, etc., parents delayed bringing their child into hospital until they were very sick. And I think maybe Path has touched on this, but the impact of being diagnosed with diabetes and being in DKA does have long-term impacts on your diabetic control and diabetic health. So we know that there are impacts on the brain in the short term, and just generally your risk of going on to have further episodes of DKA. So I think that's a really important aspect of ELSA in terms of reducing risk of being diagnosed with diabetes and being in DKA simultaneously. But yeah, to go back to your question, I don't think there was a massive drop, actually. We didn't see a massive drop in numbers. I think our numbers were slightly skewed in Birmingham because we were kind of a hub service for all hospitals in Birmingham, because we're a standalone children's hospital. So other units which weren't standalone kind of diverted to being adult units whilst we took in all the children. So it felt like it was a really heavy workload, but actually it was about the same if you looked at the numbers.
So equally to Path, I mean, in the adult population, we've seen that COVID infection seems to trigger a range of different autoantibodies in people who've had certainly been hospitalized. So, and has there been any evidence of an increase in the incidence of type 1?
So the jury's still out, surprisingly. So we saw a big rise in type 1 diabetes presenting during and just after COVID, not just more severe presentations, as Veronica said, but also a greater number. So it's really interesting. When I talk to colleagues in other parts of the country, some of them haven't seen that. So there's a big piece of work going on to collect all of the data and get a national picture.
So even during the pandemic, you were seeing increased numbers among those who'd had the infection?
Near the tail end of it.
Okay.
Yeah. So the way I think of it is that if if you think of the autoimmune process happening over many years, leading up to type 1 diabetes, if you're unwell, you put more stress on your beta cells because they need to make more insulin to control the glucose, because stress does put up our glucose, and the body therefore has to make more insulin to manage it. But if you're under stress, and we saw some stress related questions in the chat here, either psychological or physical stress, such as illness, then you're going to ask more of your beta cells. And if those beta cells are not there, you're going to unmask that deficiency. The glucose is going to go up and people are going to be diagnosed. So the question really is, has it initiated an autoimmune process, or is it a spring harvest, i.e. you're just picking up these people earlier who you'd normally pick up later on? So that's a answer we don't really have a question we don't really have an answer to. So really interesting question. And there's a few papers coming out saying that type 1 diabetes went up during COVID, but the numbers are small, and I don't think we have a definitive answer yet, in adults anyway.
Very good. So, I mean, there are a couple of points I'd like to make towards the end here, and that is, first of all, to Path, all this work you're doing, and you're not funding this out of your own pocket, are you, Path? So where is the funding for all this coming from?
So this is coming from from Diabetes UK and JDRF. So we're very grateful to them for allowing us to do this important work and allowing Birmingham to lead that. There's also money coming from the Helmsley Trust, which is the work we're doing, David. The National Institute of Health Research is has contributed to this study as well. And as Alex has also mentioned, also the Rosaries Trust is supporting this. There's also philanthropy supporting this. So we do have families who step forward to support this, who may have been affected by diabetes or know someone who's been affected by diabetes. And that's also another important way of getting important answers to the questions we've discussed today.
Mm-hmm. So I'm just going to go around everybody now and ask, how much of your work is supported by philanthropy? And people listening in are asking, how they can play a role in the next phase of the research in preventing and treating diabetes. What would be the next big project you're working on that people can support? And let me put it another way. If we were able to give you £500,000 tomorrow, Path, what would you do with it?
So there's lots we can do with that. So immediately we're thinking of expanding ELSA into adulthood, so going from age 13 up into an older age group. The bigger picture, though, is to try and develop a system in which we can delay type 1 diabetes for longer and longer and longer. So teplizumab, diet and exercise, or exercise might delay it for a short period. Then teplizumab might, if you add that on, might delay it for a bit longer. But it's also testing many other immunotherapies and building an algorithm so that we can just delay this for longer and longer. So like for hypertension, I've done the type 2 diabetes analogy, but for hypertension, you start with one drug, then you add another and another and another. And there are strong parallels with pre-type 1 diabetes because it's largely asymptomatic. But if it's left untreated, it can cause harm. And I sort of think of pre-type 1 diabetes in a similar way, that it's asymptomatic, but if you don't manage it, it can lead to type 1 diabetes. So it's building an algorithm. And David, you mentioned about where will we be in 100 years. So I don't see any reason why we can't institute a system for longer and longer delay of type 1 diabetes and pushing it further. Teplizumab has shown us the way. We've now got the first drug, and there's plenty of others with potential that are being tested. So we need to build an algorithm where we can just delay it for longer and longer and drive it out of childhood and into older and older ages. And type 1 diabetes is different in children. It's far more aggressive and nastier condition in children than it is in adults. So if we can push it later, it makes it easier for people to manage that. So
Control.
there's no reason why we can't achieve that.
Brilliant. Thanks, Parth. Same question for Tim.
Oh, excellent. Yes, absolutely. So first of all, philanthropy is absolutely fantastic. And through philanthropy and the support of the JDRF, it's allowing us to answer one of the questions that was in the chat about what other treatments as well as insulin can be offered. So Parth and Renika are very much looking at that bit, trying to prevent diabetes. Alex and I trying to look at that bit to make life a bit better for those people once they've got diabetes. And at the moment, JDRF have really helped us with a study we're about to start this year on add-on treatment as well as insulin to try and improve the overall glucose control. What would be really exciting with another philanthropic donation would be to look at some oral treatments for that. So these new drugs called GLP-1 agonists, semaglutide and others, they're being used across the spectrum as injectables once a week, but there are tablet forms coming along now as well. And wouldn't it be fantastic to be able to offer a tablet to young people rather than another injection to try and improve their diabetes? And the other bit to say is, I mean, Birmingham is absolutely the best place to work. We have a really diverse cosmopolitan population, and I'm very, very fond of that at the moment. The work that Renika is leading as the head of the diabetes service here in Birmingham with our diverse population is actually getting some of the best outcomes for children in the country, as shown by the last National Paediatric Diabetes Audit. And what I'd really like to see is that in the next 5 years, that we're sharing that knowledge through the project that I'm doing to reduce those health inequalities for everybody. And one of our challenges has to be equitable access to everybody to the new developments that are being done. So that is really key, I think, to us to try and deliver that.
Excellent. So Renika, same question to you.
Well, how can I follow Tim and Parth? My goodness. So I think, I work really closely with Tim and Parth, and as part of that team, it is around equity of access, not just to screening, but also to treatments when you've got diabetes. And I think the other aspect is around education as well. So psychological support, but also education underpinning that. Because I think for me, if you can delay type 1 diabetes from happening in a young person, so you get them through in the UK through their GCSE, through their A levels, perhaps through their first job or university, and that will have huge impacts on kind of their life going forward, but also will have huge impacts on, hopefully huge positive impacts on their long-term health outcomes. So that algorithm that Parth was talking about and that screening program being really robust to support that algorithm is a really important part of the work we would like to do going forward.
Thanks, Renika. Alex, and then I'll have my final go.
Oh, thanks, David. Yeah, no, firstly, just to acknowledge the funders. So, yeah, since I arrived in 2019, we've received money from the Rose Trees Trust and the Society for Endocrinology to support our work in type 1 diabetes and exercise. So, hopefully, showing that it's important to kind of investigate this area. In terms of that £500,000 that you're giving me, firstly, that sounds very nice. It's important to say that the project we're doing at the moment is fairly small scale, so we would need to expand this out into a larger clinical trial to really see what's going on. And also we're quite restricted to just looking at newly diagnosed patients, so really kind of looking at the broad spectrum of people with type 1 diabetes, long-term diagnosis, children is really important. And I think ultimately, in terms of making an impact, it's how we can integrate exercise with standard care effectively. So in conjunction with what Parth discovers from the ALTA study, if we know that exercise can have this beta cell preserving effect in the pancreas, then putting people on exercise interventions following their screening test could be important as well. And I think it's really just about being more precise with how we prescribe exercise. As Renika said, there's a lot of evidence, good evidence for exercise having important impact on the general health outcomes. But if we can provide evidence that it's specific to the disease and the mechanisms that underpin this, I think it will be really important and kind of hopefully advocate more uptake of exercise in the population, because I think there are some fears around exercise in type 1 diabetes, and it's obviously important to have these concerns because it is a complex situation, but hopefully studies can help ultimately provide this important evidence.
Great. So, and if I can finish, I think the work that PATH is doing with the ULSR study really makes the work that we're doing together on the novel immunotherapy that we've developed really exciting, because the prospect of taking a therapy into young children that will be completely safe to administer will reset their immune system so that the autoimmunity, that progression to destruction of islet cells is prevented, is really exciting. And the limiting factor for us is taking those treatments through the clinical trials. And we're beginning to do that now here in Birmingham. And, any funds that we could receive to help us with that would simply accelerate that process greatly and get us closer to what the Toronto Daily Star predicted 100 years ago, which is a cure. So I think now, to round up this session, I'd really like to thank, first of all, you all out there for attending this important event in the Bringing Birmingham to You series. I'd like to thank each of our panel members and the funders who've supported their work over recent years. We've tried to mention the funders in turn, and any we've forgotten or overlooked, we apologize. I hope you've enjoyed this session and have come to appreciate just how much important work is ongoing in Birmingham in this field alone. Of course, we're keen to hear from you about other areas of research that you're interested in. Please come back to our alumni events team with suggestions. And finally, thank you to the team, the alumni team, and especially Emily Timmins, for making this all happen. Thank you very much, and good morning, good afternoon, good night, wherever you may be.